So many of our breast cancer patients are on some form of endocrine therapy,
Right.
whether it's a tamoxifen or a Zoladex. There's a whole list of them.
Right.
First question is, what's the difference?
Okay, so let's start. There are different types of breast cancer. There are 4 different types, okay? And any breast cancer cells that have a sensitivity to estrogen and progesterone, those patients will require some form of endocrine treatment. And it used to be fairly prescriptive. We used to say young people can take tamoxifen and old people. We had a variety of medicines, aromatase inhibitors and or tamoxifen. I'm often asked, how long must I take this medicine for? And my quick response is, how long do you take your blood pressure medicine for? How long do you take your cholesterol medicine for? How long do you take your diabetes medicine or your antidepressants? So a lot of medicines people are put on are for life. Currently, the data around endocrine treatment shows that you should be on it for 10 years. My personal opinion is it may change for longer, and I don't necessarily think that's a bad thing, because what you're trying to do is your endocrine therapy around breast cancer, in my head, is your contraception to prevent your little cancer spermies from waking up, okay? And basically, so in young people, what we want is we put them into what we call an iatrogenic, a medically caused menopause, via a variety of techniques. And that's where you can use injections to switch off your ovaries. And then you can use either tamoxifen or an aromatase inhibitor, okay? Sometimes chemotherapy pops people into menopause. Sometimes, this country, a lot of people have hysterectomies, and then you have a hysterectomy and they keep the ovaries and they don't even know whether they're in menopause or perimenopause, particularly after chemotherapy. So then we need to check the blood after chemo and realize that things can change. Our bodies aren't, it's not a switch. You don't go menopause. The only time you do that is if you take out the uterus and the ovaries. And I'm also asked, shouldn't I just take my uterus and ovaries out? I'm quite avoidant around surgery, you know me, and I'm a surgeon. I'm like, understand when you operate, understand why you operate, and like I've got all my Yodas up there, when you don't wield your lightsaber. So know when you don't do it and how to do it. In postmenopausal women, we again can use any option, and your oncologist will go over with you what your potential risks are, such as your risk of clotting, risk to your heart, risk to your bones, and these potential side effects are small. So people don't look at the list of side effects around their cholesterol meds or any other wide variety of meds, but they're quick to do it around the endocrine treatment with cancer. And I'm not quite sure why there's not this concept of fear of cancer coming back around these medications. So a common one I get asked is weight gain. Sadly, and you heard me, I'm going for my run just now, as menopausal we get, the harder it is to maintain our BMI. It's really difficult, little tire here. And so the only thing that causes weight gain is food. Okay, yes, your metabolism might slow down and you might need less and you might feel more hungry. Latest thing Tia says, Mom, you got to drink more water. So, I drank so much water yesterday, I thought I spent the morning on the toilet, okay. But the concept is we've got to manage these things. When you're 2 or 5 or 10 and you're running around, or you Caleb's age and you're training 3 times a day, and you can have these massive plates of food. We can't do that. Okay. Do you want to ask me about other side effects?
Well, tamoxifen's got such a bad name amongst the breast cancer patients, it's become a bit of a swear word.
It's actually very, very good for you. It's a fascinating medicine. In fact, I take it in low dose. It's supposed to decrease your cancer risk, okay? It's good for breast pain. It's good for gynecomastia, particularly at the half dose. The 10 milligrams, we use 10 milligrams for sleeping cancers to decrease the chance of getting other cancers, other breast cancers. You get asked about, is it going to cause me to get a cervical or ovarian? It's not. It's uterine thickness that it can cause over time, which is no different to what we found when people were on unopposed Premarin or estrofen and they had their uteruses.
And the side effects of tamoxifen, do they decrease over the years? Is it a bit of a psychosomatic oh, my joints are sore, and 5 years later they're still sore?
So I don't think at all. I think each person's different, and each person's response to medication is different. So I often comment about my government patients seemingly have less side effects. So I don't know whether they just don't mention it because they have so many other major concerns. But each person is an individual, and I genuinely don't like the word psychosomatic, because I think that people's response to pain and different medicines is different, and it has to be managed. So we need to understand what are the driving concerns people have. So is it joint pain, vaginal dryness? I get often asked about libido, and sorry ladies, it gets less as you get older. It doesn't mean that you can't have great sex when you have sex. You just got to pop it into your calendar, okay? So I think people need to list out and not focus on so much the Google and the Facebook and so-and-so had this and so-and-so had that. Get up in the morning, look at your body, decide what you like and you don't like, what you can change and what you can't change, and work out what your symptoms are that you have. Like, I've really battled with my foot. So slowly, and you have as well.
I'm still struggling.
You wake up in the morning and you think, oh, it's so stiff, and and obviously having an injury older is harder to manage than having an injury at 20 or 16. So you really have to analyze what are the issues that are affecting your quality, and then see how they can be managed. But I think it is foolhardy to turn around and say, I'm not going to take my medicines. It's like, I'm not going to take my ARV, my diabetic medicines, my cancer medicines. And you need to be able to have an honest discussion with your doctors, or change your doctors, so that they can listen to you but help you. And that's where the allied, and I also don't like the word allied, but the part of the team that is not considered core, which I actually think is more important.
Post-diagnosis,
Absolutely.
post-treatment.
Survivorship, OT, dietetics, counselors help. Because sometimes what you consider your little core, your oncologist, your surgeon, your rad-onc, has focused and fixed, and you feel like you've fallen out the nest. And that's when you need people to help you with how are we going to train together, how are we going to accept our differences in our bodies, how are we going to manage our side effects.
I think the big problem we have as human beings is package inserts.
Absolutely.
Because every package insert could cause nausea, could cause constipation or diarrhea. Which one is it? And we become so obsessed with all these side effects on that little piece of paper that we forget about the good that the drugs are actually doing, and the need for them at the end of the day.
So I love that, because remember, a package insert, if one person in the world has had a side effect to something, it's got to be listed on that package insert, which is why exactly you said diarrhea, constipation, nausea, vomiting, headache, not headache. So I generally, around package inserts, because often doctors say, well, just read the package insert. I don't think that. Or you get an oncology list of potential best side effects or worst side effects around your chemo or your endocrine. I think what you must do is understand why you're taking your medicine, and listen to your body and see where you feel there are changes, and then we work out how to adapt it. Sometimes it's as simple as there are many different types of tamoxifen on the market, and I see some ladies are fine on one, it's like contraceptive pills, and not fine on another, or taking it at different times of the day, or maybe splitting the dose morning and evening. So there are many ways you can manage.
I think it's just about being educated about the benefits in the long term versus the minor side effects and challenges we've got to face now while we're doing our treatment.
Absolutely. I always love these chats. So thanks again, and we'll see you next week.
Thanks, Carol. See you next week.